I'm going to do a reading from the book Medical Herbalism, Science and Practice of Herbal Medicine by David Hoffmann. This was published in 2003. I'm going to read from the digestive system chapter on the topic of constipation. Infrequent or hard stools or difficulty passing stools may involve pain during the passage of a bowel movement, the inability to pass a bowel movement after straining or pushing for more than 10 minutes, or no bowel movement after more than 3 days. That's the definition of constipation from the Merriam-Webster Medical Dictionary. Constipation can be defined as difficult or infrequent passage of feces. It must be seen as a symptom, not a disease state in its own right. Proper diagnosis is thus vitally important. Acute constipation constitutes a definite, recognizable change for an individual, and an abrupt change in bowel habits can indicate the presence of organic disease. In chronic constipation, however, there is an ongoing problem with normal bowel movements. In such cases, the ideal is to normalize and regularize bowel movements through dietary change. The most common cause of constipation in Western cultures is lack of dietary fiber. However, there are some important but less common causes that the practitioner should bear in mind. Examples range from irritable bowel syndrome, diverticular disease, and serious infections, for example, appendicitis, to painful anal conditions that make people afraid to open their bowels. The condition may be congenital, or it may be caused by endocrine disorders, nervous system conditions, or diseases of the large intestine. Other possible causes of chronic constipation include drugs or toxins that affect bowel motility, long periods of immobility, stress, and depression. Whenever a specific cause can be determined, it should be treated. There are many herbs that can help alleviate the discomfort of constipation. Rather than discuss all of the individual plant species, we instead can generalize about appropriate herbal actions. Laxative remedies are obviously relevant, but others must be considered. For example, bitters may be very helpful because they cause a general stimulation of the digestive process. When stress or depression is a factor, consider relaxing nervine, antispasmodic, and antidepressant herbs. A number of different types of laxative herbs may be used. Bulk laxatives are fiber-rich foods and herbs that offer the only truly safe long-term treatment possibilities. They act slowly and gently and are best used by gradually increasing the dose taken every morning and evening until a softer, bulkier stool is achieved. Secretory laxatives promote bowel movement through stimulation of bile production in the liver. Hepatic herbs act as secretory laxatives. Stimulant laxatives are anthraquinone-containing herbs that stimulate peristaltic movement directly via an impact on the nerve ganglia of the gut. Carminatives may be helpful in easing the pain and discomfort that is often associated with constipation. Laxatives. Laxatives promote defecation, relieving constipation. As noted, constipation itself is not a disease, but rather a symptom that may result from any of a broad range of underlying causes. In addition to the possible causes discussed earlier, constipation may be related to a variety of subjective factors such as stress and diet, or from a patient's impression of what constitutes quote-unquote normal bowel habits. Normal size, frequency, and consistency of fecal output are difficult to quantify and are subject both to personal variation and to sociological patterning, of which the makers of laxatives take full advantage. There is no distinct advantage to having frequent bowel movements. While having a bowel movement once daily may be considered average, having one several times a day to once every several days may also be seen as normal. If hepatic function is normal, fear of quote-unquote auto-intoxication due to retention of colon contents is unfounded. However, increased hardness of feces and reduced colonic motility, frequency, and bulk do occur, mainly due to dehydration of material that remains too long in the colon before expulsion. Bulk, softness, and hydration of feces are very dependent on the fiber and water content of the diet. Thus, sufficient intake of dietary fiber and water is a mainstay in any regimen for the treatment of constipation. Types of laxatives. The precise mechanisms by which laxatives work remain uncertain because of the complex factors that affect colonic function. However, there are three main ways in which laxatives work. 1. Cause retention of fluid in the contents of the colon, thereby increasing bulk and softness and facilitating transit due to their hydrophilic or osmotic properties. 2. Reduce net absorption of water and salt through both direct and indirect actions on the colonic mucosa. And 3. Increase intestinal motility, decreasing the absorption of salt and water because of increased transit time. Indeed, abnormal colonic motility may be a contributing factor in constipation. Bulk forming agents. Bulking and swelling agents are gentle laxatives that simulate the physiologic effects of a high-fiber diet. Bulk forming agents are widely recognized for their value in the long-term management of irritable bowel disease and chronic diverticulitis. These agents, which can be utilized as supplements to dietary fiber, are polysaccharides and celluloses derived from grains, seed husks, or kelp, and include bran, psyllium, methylcellulose, and carboxymethylcellulose. Bulking agents are normal components of food. Indigestible carbohydrates, which undergo complete or partial breakdown by the intestinal flora, physically stimulate activity through their bulking action, speeding the transit of material through the intestinal tract. Swelling agents are distinguished by their capacity to form mucilage or gels. Mucilaginous swelling agents are generally taken in some medicinal form, for example, psyllium husks, rather than as food per se. Like bulking agents, they are composed of indigestible carbohydrates, but they undergo little or no degradation by intestinal flora. Bulk-forming laxatives have little effect on transit time through the small intestine, but they do affect colonic transit time. The heavier the stool weight, the shorter the colonic transit time. These agents also stimulate bowel motility by modifying the intestinal flora. The colon is inhabited by more than 400 species of bacteria. The precise makeup of this intestinal flora is determined by the nature of the available substrate. Fecal bulk provides the bacteria with a substrate for proliferation, which causes an increase in bacterial mass and stool weight. Because the bacteria are specific to particular substrates, a latency period of 4 to 6 weeks is needed in order to establish a more suitable intestinal flora. Human digestive enzymes do not affect the celluloses, hemicelluloses, lignins, and pectins contained in bulk-forming agents, so these pass unchanged through the small intestine into the colon. There, bacteria break down all or part of the bulk materials, releasing short-chain fatty acids, along with methane, carbon dioxide, and molecular hydrogen. The short-chain fatty acids promote the absorption of salts and water and provide osmotic stimuli that encourage motility. Swelling agents also soften the stool, facilitating passage through the bowel. Gases generated in the lower bowel may cause bloating and flatulence, and constipation may initially worsen when bulking agents are introduced. Generally, this issue is resolved once a new intestinal flora is established. Starting treatment with half the normal dosage may be helpful. It is imperative that bulk-forming agents always be taken with sufficient quantities of liquid, as esophageal and intestinal obstruction can occur when fluid intake is inadequate. A few other cautions are in order. Intestinal obstruction and impaction may occur after the administration of bulk-forming agents, especially for patients with pre-existing gastrointestinal disease. People with gastrointestinal stenosis, narrowing of passages or sphincters, ulcerations, or adhesions should also avoid these agents. Dietary fiber. Sources of dietary fiber include whole grains, bran, vegetables, and fruits. Plant cell walls consist of varying quantities of fibrous polysaccharides, mainly cellulose, matrix polysaccharides, pectins and hemicelluloses, lignins, cutin, waxes, and some glycoproteins that are resistant to breakdown in the digestive tract. Dietary fiber acts as a laxative by several mechanisms. Dietary fiber binds water and ions in the colonic lumen, thereby softening the feces and increasing their bulk. However, the water-binding capacity of fiber is insufficient to combat secretory diarrhea. Dietary fiber can support the growth of colonic bacteria, thereby increasing fecal mass. Some components may be digested by colonic bacteria to metabolites that contribute to laxative action by adding to the osmotic activity of the luminal fluid. Colonic fermentation of water-soluble, non-cellulose polysaccharides, such as pectins and gums, can decrease stool water, apparently by producing metabolites, such as short-chain fatty acids, that directly influence colonic mechanisms of fluid and electrolyte transport. Foods differ widely both in fiber content and in the type of fiber they contain. Grains and cereals contain a preponderance of insoluble, poorly fermentable fibers. Their ingestion shortens intestinal transit time and increases stool bulk. Fruits and vegetables contain more water-soluble fibers that result in a moist stool, but have less effect on transit time. Usually 20 to 60 grams of dietary fiber is a sufficient daily intake. Psyllium, lignin, and pectin bind bile acids, which reduces the rate of their reabsorption by the intestine and promotes excretion. The consequent enhancement of hepatic synthesis of bile acids from cholesterol may reduce plasma levels of low-density lipoprotein, LDL, cholesterol. Over time, bulk-forming agents can help relieve symptoms of irritable bowel syndrome and diverticular disease. Osmotic agents. Osmotic laxatives are chemicals that cause water to be retained in the bowel through osmosis, thus increasing the water content of the stool. This mechanism underlies the action of non-absorbable sugars such as mannose and sugar alcohols, including mannitol and sorbitol. Anthraquinone laxatives. Many well-known laxative plants owe their efficacy to the presence of polyphenolic, quote-unquote, anthranoid compounds. These anthraquinone laxatives include 1,8-dihydroanthraquinone and its glycoside derivatives, which are contained in senna, cascara sagrada, and rhubarb, as well as aloe and other members of the Liliaceae family. Senna is obtained from the dried leaflets or pods of Senna alexandrina and other species. Cascara sagrada, quote-unquote, sacred bark, is obtained from the bark of the buckthorn tree Rhamnus persiana. Anthraquinone laxatives exert their effects by damaging epithelial cells, leading to changes in absorption, secretion, and motility. Damaged epithelial cells can be found in apoptotic bodies in darker pigmented colonic mucosa, a symptom of the condition called pseudomelanosis coli. Pseudomelanosis coli is caused by chronic use, in other words, abuse, of anthraquinone laxatives, and has recently been associated with an increased risk of colorectal carcinoma. In vitro and animal studies show that anthraquinone laxatives have a potential role in both initiating and promoting tumorigenesis. Studies in humans have also suggested that these laxatives have tumor-promoting properties. Although clinical evaluations of the long-term toxicity of anthraquinones have yielded conflicting results, preparations that contain 1,8-dihydroxyanthraquinone itself have been withdrawn from the market because the chemical has been associated with hepatic and intestinal tumors in laboratory animals. Whether the naturally occurring glycosides cause similar problems is not known. Although the short-term use of these substances is generally safe, long-term use cannot be recommended. They may cause an excessive laxative effect, leading to abdominal pain and gripping. Chronic use of large doses may produce nephritis. Anthraquinone-containing herbs are contraindicated for people with partial or complete bowel obstruction, as well as for women who are pregnant or nursing. Interactions with cardiac glycosides and other drugs may occur indirectly as a result of electrolyte imbalances. Most of the metabolites are excreted in the stool. However, a fraction is absorbed and appears in the urine, turning the urine a dark yellow or even red. In nursing mothers, anthraquinone metabolites can give breast milk a brownish tinge. Castor oil. The bean of the castor plant, Ricinus communis, contains two well-known noxious ingredients: an extremely toxic protein, ricin, and an oil known as castor oil. Used externally, castor oil is a bland emollient, but within the small intestine, the action of pancreatic enzymes releases ricinoleic acid. Ricinoleic acid and its salts reduce the absorption of fluid and electrolytes and stimulate intestinal peristalsis and hence the movement of feces. Because castor oil acts in the small intestine, accumulation of fluid and evacuation take place rapidly and are relatively complete. The cathartic effect is too strong to warrant use of this agent for common constipation. Appropriate use of laxatives. In otherwise healthy patients, laxatives are of secondary importance to a fiber-rich diet, adequate fluid intake, appropriate physical activity, and other non-pharmacological means of preventing and treating constipation. If such measures are inadequate, they may be supplemented with bulk-forming agents. Stimulant laxatives should be used only in unresponsive cases. When laxatives are employed in the treatment of constipation, they should be administered in the lowest effective dosage as infrequently as possible and be discontinued promptly and completely when no longer needed. If constipation is drug-induced, lowered dosage or use of alternative drugs should be attempted before using laxative medication. The use of laxatives is no substitute for treatment of an underlying disease of which constipation is a symptom. Valid uses of laxative agents include maintaining soft feces, preventing straining at the stool, especially in the elderly and in patients with cardiac disease or hernia, and evacuating the bowel prior to diagnostic or surgical procedures. Laxatives frequently are indicated both before and after surgery to maintain soft feces for patients with hemorrhoids and other anorectal disorders. For these purposes, dietary fiber or bulk-forming agents are generally satisfactory and preferable. A fiber-rich diet and related laxative agents also have an established role in the management of diverticular disease of the colon and irritable bowel syndrome. In addition to perpetuating dependence on drugs, the laxative habit may set the stage for serious gastrointestinal disturbances. Irritable bowel syndrome and other functional ills have been associated with the habitual use of stimulant laxatives. Treatment of constipation. As with many other functional problems of the digestive system, many specific herbs have been used to treat constipation by different herbalists in different cultures. As constipation is a symptom, there are no true specific treatments. Effective, commonly used herbs include Rumex crispus, yellow dock, and Plantago ovata, psyllium seed. A prescription for constipation. Rumex crispus, 2 parts. Taraxacum officinale, root, 2 parts. Pimpinella anisum, 1 part. Dosage, up to 5 milliliters of tincture 3 times a day. A stronger combination, including anthraquinone-containing herbs such as senna, may be appropriate in some cases. However, a dietary approach focusing on the rational use of fiber is the most effective. I stress the word rational here because becoming an oat bran addict is not far from drug abuse.